Morning, ladies and gentlemen. I'm Kevin Sung, and I'm going to talk about the multiphasic learning curve for robotic rectal surgery. Okay, we have no disclosures. So, laparoscopic rectal resections are technically challenging, and its uptake is relatively slow. So, robotic surgery, with its technical advantages, may attenuate this learning curve and has been shown to be feasible and safe. So our aim was to define the learning curve for robotic-assisted rectal cancer surgery, and we hypothesized that there are multiple phases in this learning curve. Our study was IRB approved, and we extracted data from this prospectively maintained colorectal database, where we extracted consecutive patients who underwent robotic rectal surgery between 2006 and 2011 by a senior laparoscopic surgeon. We use the cumulative sum technique as objective means to define the learning curve, as opposed to just chronologically dividing the study population into arbitrary fractions for analysis. We enlisted the help of a statistician to help us to draw the Q-sum charts and subsequently identify the various phases from these charts. After placing our patients in chronological order, based on operation dates, we use Q-sum to analyze the total operative time, the robotic time, console, as well as docking times. And we use these other statistical methods for our analysis as well. From our results, we identified 970 patients who underwent resections, colorectal resections, and excluded 40 open, 702 laparoscopic, 2 hand-assisted, and 9 transanal resections, before being left with 217 robotic-assisted cases. And from these, we excluded a further 13 right hemicolectomies, 6 high anterior resections, and 1 panproctocolectomy with ileal pouch anal anastomosis. And this left us with 197 robotic rectal cancer cases, which formed the basis of our study. So for our patients, our study population, most of the tumors were in the low rectum, less than 7 cm from the anal verge. And not surprisingly, most of them underwent either low anterior resection or intersphincteric resection. This chart shows the median and mean values for our operative times, the total operative, robotic, console, and docking times. Okay, these 3 charts here basically show the data for total operative time. The first diagram showing the raw operative times plotted against case number. And the second chart showing is a Q-sum chart of this operative time. And finally, the third chart is a fitted model line plot of the second Q-sum chart, this being a 4th order polynomial model from which we derive the 3 phases. We did the same for total operative robotic time, console, as well as docking times. So we found that for operative time, robotic, and console times, there was a very similar pattern with 3 phases being identified. The first phase being 35 cases, consisting of an initial short learning curve. And the second phase, the subsequent 93 cases, where we found there was a steeper learning curve with more complex cases. And finally, the third phase representing the completion of our learning curve. Docking time, on the other hand, had a much simpler pattern with a short learning curve of 35 cases, beyond which no further learning pattern was apparent. So the 3 phases that we identified formed the basis of our analysis, and we compared the data within the 3 phases. And for the perioperative demographics, there was no significant difference. But we found that for the latter 2 phases, there were significantly more tumors that were low, less than 7 cm from the anal verge. More patients required preoperative neoadjuvant chemoradiotherapy. More patients required splenic flexure mobilization. And they generally, in the latter 2 phases, had a longer length of hospital stay with a smaller pathological tumor size. In terms of post-operative complications, there were no significant differences within the 3 phases, but we did identify a non-significant trend towards a higher complication rate in the latter 2 phases. So from our study, we identified two distinct learning curve patterns. The first being a simpler learning curve pattern from docking time, where there was a short learning curve of 35 cases. And the second being the more complex multiphasic curve of operative, console, and robotic times, where the first phase represented initial learning curve, followed by a steeper learning curve in the second phase, and the third phase representing the completion of our learning curve. We found that in the latter two phases, there were significantly more low rectal tumors, more required spleen infection mobilization, preoperative chemoradiotherapy, and smaller tumors. We noticed a non-significant trend towards a higher complication rate in the latter two phases, although none were specifically related to the robot. And our patients also had a longer length of stay in the latter two phases. These last two factors may be related to the increased complexity of cases we tackled in the latter two phases. Our conversion rate was 0. This may be in part related to our surgeon's extensive laparoscopic experience, and his personal conversion rate for laparoscopic colorectal resections for rectal surgery is less than 1.5%. Our limitations, this being a retrospective study, we did not make a corresponding comparison with the learning curve for laparoscopic rectal resections, which would be interesting. And this data represents only that of one surgeon and may not be representative of our surgical community as a whole. While the use of operative time as a surrogate marker for learning has its critiques, but we feel that it's a fair reflection of the entire learning curve process, which not just reflects the surgeon's technical ability, but also the general efficiency and proficiency of the entire OR team and the supporting infrastructure. Okay, so in conclusion, learning curve is not just limited to speed, but also involves other aspects such as gaining the confidence and capability of handling a whole spectrum of surgical situations. And for an experienced colorectal surgeon, at least 3 phases are identified in the learning curve for robotic-assisted rectal cancer surgery. Thank you.
Questions for this paper? I'll start. Dr. Singh, how do you define conversion from robotic to laparoscopic? What percentage of the case has to be done robotically for you to qualify that as robotic?
Okay, basically, I mean, it's a good question. Basically, we employed a single stage, totally robotic procedure. But having said that, when we talk about conversions, we actually mean conversions to open. Okay, when we do a totally robotic cancer surgery, inevitably there will be parts of the operation that will be done laparoscopically. So this would include the part where we do, for example, the stapling of the distal transection. So that is done through the laparoscopic method. So to a certain degree, there will be some cases where robotic procedure prove a bit of a technical challenge. And in that case, our surgeon would perform some of the parts in a hybrid approach. For example, spleen flexure being one example. So unfortunately, our data is not able to capture how much of the cases actually had part of the operation that was done laparoscopically. But when we talk about the conversion rates, we actually meant conversion to open. So, I mean, that brings on to my next point that I think having a surgeon who is experienced in laparoscopy is a very useful technique, because in certain cases, for example, splenic fracture, where there are difficulties in mobilizing, it certainly helps having the experience to complete the operation using a laparoscopic approach rather than conversion to open.
I have a question.
Yeah.
So have you noticed, it seems like the laparoscopic experience of the surgeon that was doing these cases was vast. Any differences, the robotic experience better in terms of the learning curve compared to laparoscopic surgery? Do the surgeons think that they learn robotic surgery faster, or they were able to do robotic surgery faster than?
Yeah, as I mentioned in one of my limitations, I think one of my regrets is that we do not have a similar learning curve for laparoscopic surgery. But yes, our thinking is that we believe the learning curve for robotic surgery is more not as steep as a laparoscopic surgery, and certainly the use of robotic rectal surgery may increase its uptake of a minimally invasive rectal cancer surgery. Yeah.
Thank you very much.
Okay, thank you.